So I'll be speaking on the PROFOUND trial. Though this is so just a background of the PROFOUND trial. We all know that we are moving away from what in the all tumors in one basket, or treating everything in one go. So to probably genomically profile that tumor and then probably target that and then use the targeted agent. So in that regard, the prostate is not behind now. Now we are inching towards that particular momentum. So we know that DNA repair gene aberrations, which are there in patients who have prostate cancer, be it regional or biochemically recurrent or a metastatic prostate cancer. 1/3 of them can have these particular gene abnormalities. So amongst that, the BRCA2 heads the list, which is more common, and then the BRCA1 ATM. So these three are more common compared to other HRR mutations, which I'll elucidate later. Next slide, please. So in that, even NCCN guidelines acknowledge that the prostate cancer is a heterogeneous disease, and hence classifying into various risk factors, and the outcome of these patients are completely different as far as the prognosis as well as the outcome is concerned. Next slide. With these points in mind, and the rationale of using PARP inhibitors in mCRPC came into vogue. So we know that despite significant progress in the systemic therapy, metastatic CRPC continues to be lethal. The median overall survival is to the tune of around 2 years plus. So mCRPC is molecularly heterogeneous, and up to 30% of mCRPC harbor deleterious alterations in DNA repair genes. So including those with the direct and indirect routes, so that is homologous recombination repair genes, HRR mutations. So these alterations confer sensitivity to PARP inhibitors, of which BRCA1, BRCA2, ATM are most well characterized. So the anti-tumor activity of these PARP inhibitors were learned from the other solid organ malignancies, specifically the ovary and breast cancers. Next slide. So with this background in mind, the PROFOUND trial came into vogue. It's a phase 3 randomized open label trial in patients who carry HRRm, that is the homologous recombinant repair mutations in metastatic CRPC. So HRRm was done by Foundation 1. So patient who had a metastatic CRPC and had an HRRm mutations were randomized into two cohorts, the cohort A and cohort B. They should have been assessed by independent investigators as a radiographer of progression on either of one of the agents, like either a new hormonal agent, that's either abiraterone acetate or enzalutamide. So either of these agents they should have received for metastatic prostate cancer prior. The good performance status, they shouldn't have received any PARP inhibitors previously. Next slide, move ahead, please. So they have been characterized into cohort A and cohort B. The cohort A consisted of a BRCA1, a BRCA2, and ATM mutations, and the cohort B consists of other HRRm mutations, which I'll elucidate later. So move ahead. So they were randomized in 2:1 with to olaparib versus physician's choice treatment. The ones who has received abiraterone would receive enzalutamide in the physician's choice, vice versa. So in either cohort A or cohort B, there is 2:1 randomized to either olaparib or physician's choice. Next slide. Move ahead. So move ahead, please. The endpoint of the study, the primary endpoint of the study was the radiographic progression-free survival by independent review in a cohort A. So this was a primary endpoint, as this consisted majority of the patients had this mutation consists the majority of the patients as well. Hence, the primary endpoint was radiographic PFS in cohort A. And the key secondary endpoint were the overall response rates in cohort A, and combined in cohort A as cohort B, the radiographic pre-progression-free survival, and time to pain progression in cohort A, and overall survival in cohort A, and the safety and tolerability. So these were the key secondary endpoint. Next slide. So the PROFOUND trial, as I was talking about, the cohort A consisted of 3 mutations: BRCA1, BRCA2, BRCA, and ATM. as these are very common mutations that were found in the prostate metastatic CRPC from the earliest studies. And we also know that the early studies have done with these 3 mutations, and there was a benefit of using olaparib in them. So the cohort B, this was almost an exploratory analysis to check whether these other mutations would also be benefited by the PARP inhibition. So in that, all BRIP, CDK, BARD, CHEK mutations, and FANKL and RAD51, all these mutations, whenever we stand for that, we find some of these mutations, would they benefit also from PARP inhibitors? That was more of an exploratory, as the numbers of these mutations are very, very limited. Next slide, please. Next slide. So the baseline characteristics were well balanced between the 2 arms. This is a bit busy slide, but what I'll just draw your attention is that the age at presentation, age at randomization, we know that the prostate is a disease of elderly. We just see here in the first the row that patients up to 85, 86 years and up to 90 years were enrolled in the study, indicating that using olaparib in the elderly as well is going to be beneficial if they carry this particular molecular abnormality. So hence proving that even an elderly can be have been enrolled in this particular study. So we also know that the metastasis at the baseline, the de novo metastatic disease, was present in around 23% of the patients. So which we know that patients with a de novo metastasis carries a bad prognosis compared to patients who have a locally advanced localized disease. And we also know the visceral metastases were included in around 30% of the patients. And patients who have alterations in the genes, that's the BRCA2 is considered the most, which is considered around 50% of the patients compared to other mutations. So this was the baseline character which we want to highlight. Next slide, please. Next slide. Also, what I just want to highlight here is that patients who have received a prior treatment. So if you just come to a 4th row here, a prior new hormonal agent, only enzalutamide was received in 42% of patients. Abira have received almost in 40%, and both Abira and enzalutamide in around 20% of the patients. The patients also received a previous taxane. So almost 65% of the patients have received a previous taxane. So these we can understand by this particular slide that they are a heavily pretreated disease, and hence carries an importance that this molecule with an endpoint will be really helpful in this particular subset. Next slide. Next slide, please. So I already has elucidated that the mutations that have been carried are BRCA2, ATM, and CDK112. So these are most commonly involved mutations, almost constituting to 90% of the mutations which have been studied. The rest of them are less than 10%. Next slide. So coming to a primary endpoint, that is radiographic progression-free survival in patients with cohort A, that is BRCA1, BRCA2, ATM mutations. So I'll concentrate on cohort A first, and then the combined cohort A and cohort B. Primary endpoint first, and then the secondary endpoints. So there was a clinically meaningful benefit that's 7.39 months versus 3 months, almost doubling of the PFS, and which was with a significant hazard ratio of 0.34 and a p-value of less than 0.001. And if you just see the curves, early separation of the curves as early as around 8 weeks, so indicating the benefit of olaparib starting early. And at 6 months, there is 59 versus 22%, and also at 12 months, there's a significant benefit maintained with olaparib versus physician's choice. Next slide, please. So if you see the subset analysis, subgroups of the patients who had the BRCA1, BRCA2, and ATM. So whether the patients who have used a previous taxane or not, the measurable disease is there or not, visceral disease is there or not, and irrespective of the performance status, irrespective of the age, ethnicity, all of them benefited from using the olaparib. Next slide, please. So if you see the secondary endpoint in a cohort A, that is the overall response rate. In an olaparib arm, 33.3% responded to a measurable disease. Some of the patients who had lymph nodal disease or visceral mets So there the response was seen to the tune of 33.3% versus only 2.3% in a cohort A. Next slide. So at an interim analysis, olaparib had a, if you talk of overall survival analysis, so there was only interim analysis, and just on 20th of this month, there was a final analysis because number of events were insufficient in 2019 ESMO. Hence, there was an interim OS which was done, and that was also significantly better, 18.5 months in the olaparib versus 15.11 months with hazard of 0.64, was consistently good with at 6, 12, and 18 months, favoring olaparib in a cohort A. Next slide. So if we combine the, now I'll be talking about the secondary endpoints in the combined cohort A and B arm. So that is the clinically meaningful improvement in patients in patients who have been treated with olaparib, and this was the radiographic progression-free survival in combined cohort at A and B. We just see the magnitude of benefit is comparatively lesser, but still it's statistically significant, indicating that probably cohort B would benefit less compared to these three mutations, that is the BRCA1, BRCA2, and ATM benefited the most. Nonetheless, the other mutations also benefit, but the magnitude of benefit is lesser as the number of these patients enrolled were lesser. But this is an exploratory analysis. We need to know the more studies, and probably definitely we edge on giving treatment for these, the olaparib for these patients as well. Next slide, please. So if you just see the subgroup analysis of RPFS in both combined cohort A and B, it is not dissimilar to compare to only cohort A. All of them benefited whether they received a taxane or any kind of meds, and irrespective of the age, all of them seems to be better with olaparib. Next slide. So also the overall response rate in combined cohort A and B is magnitude of that response is compared to lesser. That was 33% versus 21% here. In cohort A revealed in 33%, in cohort A plus B is 21% versus 4.5%. Next slide. So there is the OS in intention to treat population combined arm. So we know that OS was interim OS in the cohort A was better, and we know that 80% of these patients, just one more point, the 80% of these patients crossed over to olaparib at the interim analysis because it showed a benefit. So despite 80% having crossed over to the olaparib arm, it showed overall survival benefit, indicating that still olaparib is beneficial at 6, 12, and at 18 months. And if you just see in quantitative terms, the median OS is 17.5 months versus 14.2 months with hazard of 0.67. Next slide, please. So this is the secondary endpoint of median time to pain progression, which is also significantly better in patients who have been used the olaparib. Next slide. So also the median time to pain progression was better in both cohort A and B arms. Next slide. So next slide, I'll just summarize the results of this in the next slides, please. Next slide, because of the paucity of time. So we know that the magnitude of benefit in different mutations, the BRCA2 benefited the most, and then followed by this. So the RPFS benefit is greater for olaparib compared to other physician choice in cohort A and B, irrespective of whether the patient has used prior taxane or not. Next slide. Next slide, please. So this is also the same. The prior taxane use did not differ because it's a benefit. Next slide. Next slide. So the median duration of olaparib in cohort AB was definitely much more than the physician choice. So this is just a profound summary results where radiographic progression-free survival for cohort A and cohort AB both were much better in olaparib compared to others, and other significant secondary endpoints were also better in olaparib arm. there's no impact of taxanes, prior taxane usage as olaparib benefited in patients who have also used the taxanes. Safety profile, we all know that with our usage of olaparib in ovaries, that that the anemia as well as upper GI symptoms are nonetheless similar to what we have used in others. The anemia is more common as the patients in this here bone metastasis and the prior taxane usage would result in around 20% of grade 3 anemia in this particular trial. Next slide. So the adverse events. Next slide. Next slide, please. One moving. Next slide.
Is other slides not moving?
Okay,
Yeah.
they're not moving. So I think this summarizes the adverse events are not different from other diseases. So yeah, this is the previous slide. This is at March 2020 data cutoff at the ESMO 2020 virtual meeting has shown that the overall survival benefit of olaparib was significantly better compared to the compared to the physician's choice. The key takeaways are the PROFOUND is the first positive biomarker driven selected phase 3 data evaluating targeted therapy in men with HRRm, mCRPC, and this was really beneficial, whether you consider the RPF as a primary endpoint or the secondary endpoint. Despite more than 80% crossover, the olaparib did better in terms of OS, and the recent update also shows the benefit of overall survival, more so in BRCA1, BRCA2 ATM, and less pronounced in the other mutations. It's well tolerated, and the safety profile is generally consistent with that I've seen in the other cancers. So next slide. With that, the guidelines also recommend testing the molecular profile, that is genomic profile in the prostate cancer, especially so in the metastatic setting, and then recommend olaparib in that particular context. So with that, I thank you organizers and thank you AstraZeneca for giving me a participate. Thank you very much.